And in that case, carrying a bulky device across a hospital and, the size of Brigham and Women's Hospital, going through multiple elevators is extremely challenging. And, in that case, having a handheld device that you can take with you, which gives you reliable imaging of the patient, and you can perform a patient procedure safely at the bedside. So I think it again goes back to what is the need of the patient in that moment.
Hello, everyone, and thank you for listening to another episode of our podcast. Today, I'm speaking with Dr. Hassan Sajjad, the ICU Medical Director at Brigham and Women's Faulkner Hospital and an instructor of medicine at Harvard Medical School. Hassan has a comprehensive background in managing intensive care units, emphasizing value-based care delivery, and he also serves as the former ICU Medical Director at Mercy Medical Center in Cedar Rapids, Iowa. Hassan, thanks for chatting with me today.
Thank you so much. Thanks for having me.
All right. Well, before we get deeper into our podcast, maybe you could take a moment to tell us a bit more about yourself and your background.
Yeah, so as you mentioned, I'm a primary critical care physician. I live and work in Boston, predominantly at Brigham and Women's Faulkner Hospital, which is part of the MGB healthcare system. I serve as the medical director over there. I'm originally from Pakistan. I was born and brought up in Pakistan. I did my medical schooling in Pakistan, moved to the US for my postgraduate training, and since has been here.
Excellent. And maybe just peeling back the onion a little bit. So what interested you in medicine? You're growing up in Pakistan. Why did you choose this vocation?
Yeah, so my story I think is a little bit unusual. I don't have any healthcare providers in my family. I didn't have any thankfully experiences with a medical system until I started my medical school. So it was purely the love for biological sciences that really attracted me to medicine. Just the understanding of human body at its core and the effect of health and disease on the basic functioning of the human body. So that's how it started. Obviously, this profession is really noble and gives you a purpose to what you do every day. I really enjoy the fast pace and the exciting nature of medicine as well. And thinking back, even in early kind of part of my medical school, I was really attracted to medicine because it had wide career options. So you could be a teacher within medicine, you could be a researcher, you could be a bedside clinician. But I think at the crux of it, it was the love, the passion for biological sciences.
That's super interesting. So you came at it with more of a cerebral passion, kind of interest, but you actually ended up in one of the most hands-on, intense, applied areas of medicine, like critical care. Like you're literally holding the patient's, heart, beating heart, keeping them alive. That's a kind of interesting shift, right? Coming at it academically more cerebrally and ending up with kind of, sleeves rolled up right in the heart of care delivery.
Yeah, that's absolutely true. I still remember, I think this kind of change happened when I was a third year medical student. And, as third year students, we would start rotating with our attendings and actually seeing patients outside of the lecture based or, problem based sit down sessions over to the bedside. And we were rounding in the ICU where one of our patients, I still remember a young patient with electrolyte abnormalities from end-stage renal disease, pneumonia on ventilator, coded. And, as medical students, this was the first time we were seeing someone
Wow.
in a code blue situation. So our attending, was great. She wanted to involve the medical students and she asked for volunteers who could do CPR for the patient. And I was one of the volunteers. And I vividly remember that was the time I was like, I actually saved a life, helped saved a life today.
Wow.
And that's how, it kind of turned into a passion for critical care and pulmonary.
I just got goosebumps, Hassan. I'm not kidding. Very interesting. And so you're starting this career down the critical care path. What prompted you to move from Pakistan to the U.S. and do your training at Harvard?
Yeah, so opportunities for better education, better research collaborations. We know that US is the leader in healthcare, in critical care, in pulmonary, and a lot of other specialties. So kind of looking for those opportunities to hone my skills.
Okay, and then you're graduating. It sounds like your first big career move was into Iowa. You're moving from Pakistan to Boston area, and next thing you know, you're in Cedar Rapids.
Yeah, yep, absolutely. It was a big change, on I think all levels, culturally, temperature-wise,
Oh,
weather-wise, from hot, humid weather with temperatures in the hundreds to minus 20 degrees, in the Iowa cold. So yeah, it was a change. So I left Karachi, where I did my medical school, came to Indianapolis initially, where
mhm.
I did my internal medicine residency. So I was there for 3 years. Then me and my wife, we moved to University of Iowa. And I interviewed all around the country for fellowship, but University of Iowa was one of the places that I really, really enjoyed. The people, the mentors over there that I found, the kind of clinical and research training. So that was the decision we made, and we stayed in Iowa after my fellowship training, and recently we moved to Boston around 3 years ago.
Oh, okay. Okay. So you're now in Boston working inside of Brigham and Women's. And I know
Correct.
recently that system also went through a material change, right? It was owned by partners and then MGH and Brigham merged. And did it maintain its value-based approach? And partners was kind of moving towards a payer provider arrangement, right? Where it had kind of both the care delivery and the care insurance side. Tell me a little bit about the current health system. What does it look like now?
Yes, yeah, absolutely. So, as you mentioned, Brigham and Women's is now part of MGP, which is Mass General Brigham. They're the two large academic centers, which is Brigham and Women's Hospital and Mass General Hospital, in addition to a bunch of community hospitals that are within the system. I would say Brigham and Women's and MGP generally is a leader in value-based healthcare. There's a lot of focus on how we can increase value for our patients, how we can move from the previous fee for basis model over to more of a value based model, where we're kind of holding our providers accountable to the value they're creating, engaging the patients in the process of their healthcare, and using technology to measure patient related outcomes.
Yeah, that sounds like a very clear synopsis of what value-based care is, and I appreciate that MGB is really at the forefront of that. If I step back, like let's unpack that a little bit because it
Yeah.
does seem like the promise of value-based care is yet unfulfilled. Is that your sentiment as well? And if so, then why is that, or what can we do to change it?
Yeah, yep. So absolutely. If we start with the concept of value-based care, I think the concept is fairly simple, right? It's the value created for our patients as measured by their outcomes per dollar spent on the patient. However, I think this change in just healthcare in general will require major strategic and organizational changes in the way we deliver care, in the way we measure care, and in the way we pay for those services. I think, there are a few challenges over there. So first, I think there's a mindset challenge, right? You need to get the healthcare systems, including the providers, shift from a fee for basis model over to a value based model, which in some situations may have some financial uncertainties as well.
Mm.
Collecting that data, which measures the value for the patient, as we call them, the outcomes, is another challenge. Who is going to measure those data points? How are they being collected, and how are they being interpreted? So I think there's some challenges over there which need to be worked on, but I think this is the future.
Maybe if we could double click on the concept of measuring outcomes, because it strikes me, we're still early. Really, the measurement of outcomes, I think, started in a material way with the adoption of EHRs, right?
Yep.
The incentives that came into place following the economic crisis of 2008, 2009. We start to see adoption of EHRs. Medical records charts became digital. And yet, there's this concept of the longitudinal chart, right? Of like what happened over the lifespan of the patient, and we have to weigh the outcome, which could be years down the road, relative to a decision you have to make at that point in time. Like, and it strikes me in particular what you're doing in ICU, it's very transactional. You have to deal with a specific issue right there. And, the long-term outcome will unfold over time. So how do you reconcile between the need to incentivize providers to make the right choice at the right time when the actual measurement of the outcome over time is going to be much harder to correlate?
Yeah, absolutely. I think This is a great point, and one of the major kind of challenges that we are dealing with value-based healthcare.
Mm.
My view on value-based care has changed and evolved as I attended. I was invited to participate in an intensive seminar, which was housed at Harvard Business School, led by some of the pioneers in value-based healthcare over there, and had a global representation. So I think if we categorize value-based care into outcomes that can be measured within a very short duration of time and outcomes that cannot be measured immediately, I think that would be really helpful. So, for example, orthopedic surgery. You go and you have, bad knee, you need a knee replacement. That's an outcome you can measure within weeks to months. So you can give the incentive to the orthopedic surgeon saying, this person came in with knee pain. You get a certain amount, dollar amount to address this, whether that is through physical therapy first and later surgery, whether that's through surgery to start with and physical therapy afterwards. They manage any potential complications within the same dollar amount. And you check with the patient, at 2 weeks intervals, 4 weeks intervals, and 3 months interval to see how their pain has improved, because that's a very specific point that you can measure in a rather short duration of time. ICU or inpatient medicine is extremely challenging, right? You come and you have a patient who has multi-organ failure. Their kidneys aren't working, their lungs aren't working, they're on the ventilator, their glucose is really high, they're on vasopressors, and you're trying to create value for that patient, whereas you know that there's so many factors playing a role, and some of those are really not in your control, right? You cannot really control the ongoing inflammatory response from underlying sepsis. But I think there's a role for quality metrics over there. So you can say, okay, if you do a procedure and you put in a central line in this patient, let's make sure you don't give them an infection. If you are giving them antibiotics, you give them antibiotics within the first 2, 3 hours, which is the guideline recommendation, and you don't delay it. So you kind of make sure that you're focusing on good ICU level of care where you're preventing harm, where you're improving quality, but really not focus on metrics and outcomes in that setting, if that makes sense.
Absolutely. That's a really good explanation. So it sounds like in order to do that, though, we need a lot of data, because what we're saying is we don't know that the 2, 3 hour window for antibiotics is going to directly impact the long-term care for this patient. But we know historically, because we have a lot of data, to know that you get better outcomes if you hit this quality metric. Is that right?
Absolutely.
Yeah.
Absolutely.
And so you
Yes.
chunk up the broader picture to a series of kind of validated quality measures that are generally going to have a better outcome for the patient, even if we're not going to measure the specific one for this one, but we know historically that that holds true.
Absolutely. Yep. So, rather than seeing this as a single event, you look at, certain quality factors, which you say, if you do this, then you get your reimbursement is tied to that. If you give them an infection after putting in a central line, or if you put in a urinary catheter and that causes an infection, then you get a ding on that.
Yeah, I mean, it certainly does require a shift where now the kind of singularity of a procedure or a stay in a fee-for-service world is now chunked up into many quality measures, and you kind of need to know your scorecard. It's, by the way, it's the same in business. I always talk to my team about how I'm a big sports nut, so I'm always jealous of athletes, because I think
Yeah.
the singularity of their outcome is so clear, right? They look up in Gillette Stadium, they look up at the jumbotron, and they see, okay, it's third down and 8. There's 12 minutes left in the fourth quarter, and we're down by 6. It's kind of very clear what to do. In business, your scorecard, your P&L, your quality measures are much more complex. And it sounds like in this value-based environment, even more so, there's many, many factors that could impact your pay, your liability, and ultimately the outcome for the patient.
Absolutely. That's, I think, one of the most exciting things about medicine as a physician, right? The complexity of the care and the interactions between, how's your heart working today, and is that affecting your lungs? And if your heart isn't working, is that causing extra pressure on your kidneys? So I think, there's just so much integration in the normal functioning of the human body that sometimes it's difficult to separate those in terms of a value-based model. And I think there is certainly, especially in the outpatient or procedural world, there's a great role of, event-based, value-based care. But even in the inpatient care, adaptation can be relied upon. What are the quality metrics? How do we ensure that the patient gets the best quality of care that they can in the hospital? And, not putting it in black and white, do they survive or not survive? What is the length of the ICU stay or what is not the length of the ICU? I think those get a little bit tricky because the complexity is so much
Mhm.
in the inpatient setting, but there's still a lot of ways where we can be creative about how we make sure, because at the end of the day, our goal is to increase the value for our patient, right? And value may mean different things to different patients. For a lot of our patients, I would say in the ICU, value doesn't necessarily correlate to how many days they live, in the ICU or outside the ICU. It's also about, how is their process, and, whether they're comfortable in the process, how is their family engaged and involved, the dignity of the patient. So there are multiple things that you can look into.
I had the head of geriatric care from Northwell speaking exactly about that, about how value is, we kind of tend to think of it in much more black and white, longevity, whereas it's much more nuanced for the individual, right? When you're looking from the inside out, from the perspective of the patient, is their family there? Are they feeling better, even if they're not living as long? So very, very interesting. And I can tell from speaking with you for 30 minutes, Hassan, that you are a serious optimist, because in the face of tremendous complexity, it sounds like you thrive and you're excited by it. I think many people are overwhelmed by it, but we need more people like you in healthcare, there's no doubt.
Thank you.
Um, and so
That,
you've laid out a pretty good blueprint of helping us understand how value-based care can be kind of demystified and taken from just kind of the singularity of the outcome, which is a harder thing to measure over time and is very nuanced, to a series of more precise, validated quality measures that we know generally yield better outcomes, and therefore we try to monitor them. What role can technology play here?
yeah. So I think, the partnership between healthcare providers at the bedside and the technology community can really transform the way we provide healthcare. There's a lot of role of artificial intelligence, and we have already started seeing that, in our day-to-day operations. So, artificial intelligence, in my opinion, started off as more of an operational support to medicine. When I see patients in my clinic, we know that a major reason for provider burnout is the documentation burden. And now we have AI bots that can document everything for you, so you're done with the clinic visit. You don't have to spend another 15, 20 minutes documenting everything that you talked about. The AI bot kind of listens and generates a note for you to review further. But I think taking it forward, AI has a lot of role in augmenting the bedside care as well, especially in the staffing shortage, way of things that we are right now. So, we have been using AI in triaging radiology scans. So we have an emergency department which has 100 patients right now, and 50 of them got a CT scan. There's a radiologist who's looking at these scans in the order that they're coming in, and the first 49 might be completely normal, but the 50th one that he's going to read is the critical one. And AI can really highlight that scan for you by doing a quick kind of review of the scan and say, hey, this is the abnormality I've detected. Instead of reading it at number 50th, can you read it right now so you can save time to the providers and the patient who are at the bedside and they get the information they need to kind of treat the patient? There's a lot of work being done in the ICU as well, where we're using the metrics that we already collect for our patients, which is, their vital signs and their lab data, to predict how the patient might be doing in the next 48 hours, 7 days, 14 days. And that gives families and patients, okay, so we're looking at this predictive model. This is what we anticipate is going to happen. What is the value? Going back to value, what is the value you want to create for your loved ones, right? We know that this is how we can predict it, and this is how we can potentially intervene and change that. So I think there's a lot of role of technology in all aspects, whether that's monitoring at the bedside, whether that's predictive modeling, whether that's operational intelligence, to improve efficiency in our workflows.
Absolutely. And, having worked in the imaging AI space across different modalities, that triage use case that you noted really is the first one that got adopted. It started with intracranial hemorrhages and brain bleeds, and then evolved to a variety of lung and chest conditions. I think one of the challenges there, though, is that, the triage is very relevant in a very time sensitive environment like yours. I'd say in most radiology practices that hasn't been as pronounced. And it feels like the FDA still hasn't taken maybe the last step forward, which is to enable AI to do a rule out. Because right now, AI is in the role of what's called computer aided diagnostics. It's like the interpretive aid to the radiologist. It can help prioritize, but every scan still needs to be read by a human. I think when the AI is good enough or the FDA is convinced that it's safe enough, the intended use is appropriate, and the AI can eliminate, plain film kind of normals, especially for chest X-rays, which are very common, or chest CTs. That could be a real shift from a resource perspective.
Yeah, absolutely. I think, so this is an ongoing work, but looking at our staffing models and the staffing shortages, I think this can really augment in what we are doing. So as you mentioned, a rule out scan where it says, okay, you know, I don't see a major intracranial hemorrhage. And oftentimes even in larger academic centers, you have a training resident who would read the scans and the attending would come in the next day and would finalize the report. So using a similar model where AI is as good in ruling out a resident read and say, okay, there's no intracranial hemorrhage over here. The next day it still gets looked at by a physician. And I think there's some more work, head-to-head comparison that could be done over there. I think I was recently in a talk by one of the AI startups, and they brought a good point. They're like, maybe in 10 years, hospitals and healthcare systems would be penalized for not using AI when you can to triage these patients, to triage this in a safer manner, because the argument, as these things get a little bit more refined, could be made that, this is actually safer for the patient, more time sensitive, that we recognize something early and we still have the safety net of the actual physicians, humans, kind of looking at it, double checking it, but the triage system makes so much sense.
Maybe let's come back to another area of technology that we chatted about before we went live on the podcast, which is mobile imaging solutions. And so I know that you do work in the ICU itself, and you also do a lot of rounding. Maybe tell me a little bit about the evolution of mobile imaging solutions that allow you to make better point of care decisions without needing to move or transport the patient to the basement in radiology. And I know you've looked at portable CT, portable ultrasound. Where does that stand in your world?
Yeah, I think, that's again very, very exciting, to have these portable modalities available at the bedside. So in an ICU setting, you have a critically ill patient, they are on the ventilator, they have 3 or 4 continuous infusions that are going on. There's a nurse at the bedside 24/7 and, providers around the patient. Moving that patient out of the ICU, out of that critical care setting, over to radiology is extremely risky. It is risky because you can dislodge their breathing tube, which is essentially keeping the patient alive. It can dislodge their IVs, which are, through which the patient is getting these life-saving infusions. And it takes a whole team of 3 to 4 personnel, including the respiratory therapist. We often send a provider with the patient to the radiology because we think that it's that risky. And oftentimes we are limited in terms of doing what we can for scanning because we think that the risk versus benefit doesn't allow us to move the patient outside of the ICU. So portable modality in these situations is extremely helpful. A quick example is oftentimes when patients are intubated, they are on sedatives to keep them comfortable and sedated. And if we need a scan of the head to see my patient isn't waking up, I have weaned down the sedation. Is there a hemorrhage over there? Is there another stroke? Is there another reason? Moving the patient out of the ICU is extremely challenging. So we have tried these portable CT scanners of the head, where you could have the scan done at the bedside, and it gives you a really good information of what the patient's brain parenchyma looks like, and it can again be used as a rule out. It might not be the most sensitive thing, looking for very minute things, but oftentimes that's not the intent. We're looking to make sure there's no major stroke or no major bleed. Similarly, point of care EEG, we were talking about that. We can now do cerebral continuous EEG. So, those kind of modalities which are brought to the patient at the bedside rather than patient moving to those modalities outside of the ICU, I think have a great role in kind of enhancing the safe patient care we can provide in the ICU setting.
And maybe to understand the workflow, so in that case, you're using a portable modality, CT or ultrasound, depending on the condition. And do you still send it to radiology, or you're making the interpretation at the point of care?
Yeah, so we would look at it, but it's still read by the expert. It's still read by the radiologist.
Got it.
So we would have, again, technology platforms where the imaging are then routed over to the radiologist's workflow. The images would be uploaded in our electronic medical record. So the ICU physician can also look at it, but our usual process is that all CT scans are read by a radiologist. And similarly, in this case, if there's a portable chest X-ray, for example, done at the bedside, it's still read by a radiologist rather than by an ICU physician. They both look at it, they both make their own interpretation, but the official read comes from the radiologist. And to kind of carry forward your point of bedside ultrasound, I think there's so much role of having a portable imaging device in terms of an ultrasound that you can move from patient's room to patient's room. So, we talked about in an ICU setting, your desire is to keep the patient at the bedside in the ICU because it's very risky to move them outside of the ICU setting. But in other situations, we talked about that I sometimes work on what's called a procedure service, where we go from room to room, seeing if patients have a fluid collection that need to be drained, whether that's in their belly or in their thorax and their lungs. And in that case, carrying a bulky device across a hospital and, the size of Brigham and Women's Hospital, going through multiple elevators is extremely challenging. And, in that case, having a handheld device that you can take with you, which gives you reliable imaging of the patient, and you can perform a patient procedure safely at the bedside. So I think it again goes back to what is the need of the patient in that moment.
No, you've laid out a really clear view of both diagnostics and interventional use cases where portable imaging can help. Just on the head side, we recently partnered with a company that developed a glass shunt that you put into a burr hole. And so that for the same reason, right, that kind of patients that had trauma or brain bleed, midline shift, variety of stroke are often very, very difficult to transport. And instead of needing to move them to take a brain MR through the glass shunt that's embedded in their skull, you can do an ultrasound image, which is very cool. Like when we get a very good view of the ventricle and can do the initial triage of, the situation of the bleed and the progression of that condition. So certainly that technology is evolving as well.
That's great. Yeah, that's great to hear.
Good. So we've talked about value-based care, its adoption. We've talked about how to think about outcomes differently, not the totality of it always, but rather also how is it made up of a variety of quality metrics. We've talked about the role of technology in better triaging, better decision-making, better workflow for the patient, for the clinician, and bringing sometimes technology to the bedside instead of moving the patient to wherever technology is available. What do you see as the call to action? What could we as the technology community do better to serve you looking ahead, both in your role as an ICU expert and also just broadly for value-based care?
Yeah, yep. I think that's a great question. I think, having a strong partnership between the bedside community and the technology community makes a lot of sense. So I've been involved in some conversations with technology community where I feel like some of the startups and the initiatives are perhaps not what's really needed at the bedside at this time. So I think understanding really what is the need, how can we as the or how can the technology community aid in the current workflows of the provider community would make sense. And I think sometimes there's a lot of great collaboration and a lot of great work that's going on, but sometimes there's a little bit of a disconnect, which I feel, kind of learning from each other's experience and really understanding what the pain points are and where the focus should be. I think we are moving from more of an operational assistance from technology now really to how can we improve patient outcomes. So we started off with AI bots saying, can you help me with documentation and dictation? But I think now we need to move over to how can AI lead to safer patient care, whether that's, radiology scenario that we talked about, whether that's predictive modeling that still, keeps the physician at the bedside, but aids with, the information and the visibility of what the next 1, 2, and 4 weeks might look like for this patient. I also think technology community can also really help with partnering with the healthcare community in research. So there are a lot of data sets that can be looked into to understand how communities' health kind of respond in various ways. And technology can really help kind of looking at those larger data sets in a much shorter time than what the physician community can and come up with, some really unanswered questions.
Well, that theme that you brought up of being problem oriented versus solution oriented is very consistent with many of the people that have sat in your chair during these interviews, of really ensuring that you're solving a problem that needs to be solved. Sometimes you have a technology, and you're like, okay, I'm going to apply it this way that makes sense to me, and I'm sure it makes sense at a high level, but you actually really have to get into the detail and the problem the clinician is facing at the bedside. A lot of technology adoption has been focusing on workflow, as we've discussed. And I like how you've opened another aspect to this, which is better understanding the data and recognizing that through the adoption of a bunch of digital solutions for the past, 20 plus years, in imaging even longer than that. Electronic health records have been around for, going on 15 years. We have troves of information, and technology can go through that information and maybe understand it, find patterns or trends, or analyze it perhaps much faster than a clinician can. And that's something that we apply, very broadly in business. We think about technology as helping us to do tasks faster that relate to data. And it sounds like there's a very good opportunity to do that in medicine as well.
Absolutely. Absolutely. And, one other aspect which I think the technology community can really help us with is patient engagement as well. So if I shift my roles from an ICU intensivist, in a critical care setting, and when I see patients in my outpatient clinic, in the pulmonary clinic, using technology for the providers to know that my patient is engaged, the inhalers, the bronchodilators I prescribe them, have been picked up from the pharmacy and they're using them. If there's a patient survey which says, okay, I did use my inhaler for 30 days, this is the outcome. And, a quick kind of synopsis comes to the physician and they're like, okay, I'm providing longitudinal care. Technology is kind of helping me connect with my patients, but it's also, conducive in terms of time management. So it's not a lot of phone calls. The patient are able to be engaged. They can, on their EHR patient portal side of things, can just update, yes, I got my inhalers, they're working great, and that message quickly goes to the physician. And, I think there's a lot of role of that as well, where technology can engage patients in their healthcare, make sure that they're up to date on their preventive vaccinations and all those things, and also kind of act as a liaison between the patients and the providers in case things need to be addressed immediately.
Great. I think that ties back to where we started our conversation with value-based care, because if you think about the advent of digital therapeutics, right, digital engagement apps, the reality is that many of them have struggled ultimately to monetize. We saw kind of 2020, 2021, a huge growth in venture investments. All these apps were being created, and in the fee-for-service system, they really struggled because it was hard to think about what, in lieu of a reimbursement code for creating an app that enables a patient to, report back whether they took their medication, or to report, their self-reported symptoms. I don't know, they're testing their rheumatoid arthritis or something like that. Most of the digital therapeutics then went into the kind of employment world. They tried to basically show an ROI for insurers and for self-insured employers to show, well, it will lead to less absenteeism, less presenteeism. I think that also didn't work. And ultimately, the solution is value-based care. The solution is to say, if the sum of all that we're deploying for this patient, the care in the hospital, in the clinic, and at home, including the apps they use or tools they use to report on their progression, if all of that is kind of covered under a capitated model that is outcomes oriented, that could work. But I think the reality is today that's still very, very nascent, but maybe we need more optimists like you in healthcare that can help us really drive the adoption of these solutions in the field.
Absolutely. Yeah, completely agree with everything you said. And I think on a physician provider perspective, there's a call for being open to change. Physicians oftentimes have a healthy skepticism of a lot of things, a lot of new technology. And I think that's how we are trained, to have a healthy skepticism of, the disease processes. Is this the right differential or not for this patient? So I think you want to maintain that, but you also want to keep an open mind to technology, how that can assist you in your workflows and for better patient care. Going back to the wearables, I think that's extremely exciting. I think the challenge that I see is data management over there. I oftentimes have patients who would come to my clinic and would bring me like pages and pages of the records, and in a brief interaction, it's just really hard to make sense of that. So I think, again, technology has a great role to kind of summarize those findings, for busy providers in the clinic and send them an alert maybe, before the clinic appointment. So there's an interface between the patient wearable with what the provider sees in a more concise manner. And I know some platforms are working on that, but at least my experience is, having going through multiple pages to see what to make sense of this wearable device.
Excellent. Well, we have to start to bring our interview today to a close, Hassan, but your glass half full approach, I think, ended with a great call to action for technologists to be problem oriented, to think about multiple steps in the workflow from the bedside through to data analysis, collaborating openly with providers, with researchers. And I think a great call to action to providers to be open-minded, maintain their healthy skepticism. I know providers tend to be extremely data-oriented, and finding ways to understand the ideas that technologists bring forward and the potential value they could bring. Really, really fascinating conversation. If our audience wants to keep up with you and learn more about what you're doing, where can they go? Where can they remain in touch?
The best way would be through LinkedIn.
hmm So look you up on LinkedIn.
Yep, it's Hassan Sajjad on LinkedIn. Sajjad.
All right. I certainly will start following you, Hassan. Thank you so much for spending time with me today. I learned a lot, and I'm walking away feeling very optimistic about what the future holds.
Thank you so much. Thanks for having me. It's a pleasure.
And to all of our listeners, thank you for joining us for another episode of our podcast. That's a wrap.